7th meeting of the Health and Family Services Committee. And we appear to have a very popular legislation to discuss today, and I will allow everyone to stand if you want to. We do have an overflow room. If you want a chair, it's available in room 131. I understand that we have some fire chiefs here who can give us an up or down on whether or not this meets code, but I'm fine with it. So we, like I said, have a lot of interested parties here, so again, welcome. And I think we will go ahead and take the roll now, Madam Secretary.
Representative Bentley? Here. Representative Bowling? Representative Bray?
Here.
Representative Birch? Here. Representative Dotson?
Present in the room.
Representative Elliott? Representative Fleming?
Here.
Representative Frazier Gordon? Representative Marzian? Here. Representative Gibbons Prunty?
Here in the room.
Representative Rayburn?
Here in the room.
Representative Raymond?
Here.
Representative Riley? Here. Representative Sharp?
Here in the room.
Representative Sheldon?
Here.
Representative Tate? Representative Weber? Representative Westrom? Representative Wilner?
Here in the room.
Chairwoman Mosier?
I am here in the room. Okay, thank you, Madam Secretary. We have a quorum established to do business, and I again appreciate everyone being here. We will have some members who are in and out to attend other meetings, other committees, and are there any members who would like to introduce guests? Representative Raymond.
Yes, thank you. I want to introduce some wonderful young women from Mercy Academy in Louisville. You'll see them throughout the Capitol today. Welcome, Mercy girls. And I want to introduce my friend Shamika Parrish Wright, a leader in Louisville and a candidate for mayor of Louisville. Thank you all for being here.
Okay. All right, thank you very much. I just once again want to welcome everyone. I have a lot of good friends here today. Dr. Grodecki, it's really a pleasant surprise to see you today, so thank you for being here. And I think we will go ahead and I don't know if we have any announcements. Just silence your phones, and you know the drill. I mean, just be respectful of the space, I guess, that we have here. If you want to socially distance, we have room 131 to do that. The first bill that we will consider is Senate Bill 11. Senator and Chair Ralph Alvarado is here to discuss this legislation with us today. Please invite your guests to the table. Everyone, please introduce yourselves for the record and proceed.
Well, thank you, Madam Chair, and thank you to members of the committee. It's a pleasure to be before you. You've got a packed house. It's always a lot of attention for House Health and Welfare, which is great. I'm Ralph Alvarado, State Senate 28th District.
I'm Mark Lee.
Tim Vino with Leading Age Kentucky.
Bob White, Kentucky Senior Living Association.
Hi, I'm Betsy Johnson. I'm the president of the Kentucky Association of Healthcare Facilities and the Kentucky Center for Assisted Living.
So we've got quite a few members, folks here. This has been a bill that we've been working on for at least a couple of years and had a coalition that's kind of developed a lot of the base of the bill. We've taken a lot of input from a lot of different stakeholders that have provided a lot of input, groups like the Alzheimer's Association, the Ombudsman's Office, even the Kentucky Justice Association, lots of groups. This bill effectively just modernizes Kentucky's assisted living social model to align more closely with the vast majority of states in the union. It allows assisted living communities to deliver basic health care services in an environment that encourages meaningful aging in place. It's got endorsements of, again, a lot of the folks that are here at the table, and I'll let them kind of address the committee here in a moment, but it basically updates assisted living, not its payer source. Assisted living is going to remain a consumer-driven private pay model where the resident signs a lease for an apartment subject to a landlord type of tenant law. It merges personal care, which is a basic health services model, with assisted living, which is currently a social model, into one broader licensure category called assisted living communities. It reduces a lot of consumer confusion. I know we had a hearing of this in the interim. talking about this topic, and that a lot of people don't have an understanding of what the difference is between personal care and assisted living. So in order to remove a lot of that confusion, it merges private pay apartment style personal care homes with private pay apartment style assisted living care facilities. Also expands the definition of assisted living, which will include care from just beyond independent living until skilled nursing or a secure dementia care unit is required, without regard to physical location of the resident's apartment. Also, we have the provider. There's a lot of concern about some of the providers, that they're able to choose how much care to offer within the broader definition of assisted living. So should a provider choose to only serve low acuity social model residents who don't reside in a secure dementia unit, staffing will be different in quantity and qualification than if the provider delivers basic health care services. And providers will staff, train, and implement policies and procedures appropriate to the care being provided. And the Nurse Practice Act will control when credentialed staff will be required as well. I'll just mention we had a task force, I know, a couple of years ago. Here at we also had the cabinet involved, and this kind of aligns with the recommendations of the General Assembly's Alzheimer's and Dementia Workforce Assessment Task Force in order to get this done. The current prohibition on delivery of health services was listed as a significant problem in the 2019 task force report. So this helps address a lot of those issues. You're going to hear probably from the Alzheimer's Association in a moment. I know the Alzheimer's Association was involved in the initial filing of this bill and getting this bill formulated. It's based off of and strongly influenced by Minnesota's assisted living statute. After that initial bill was done, they had 20 requests for edits to the bill. 18 of those were done. One of them is achieved by regulation, and there's one last one that they don't like, and so they'll probably be here to oppose the bill because they didn't get the one out of the 20 that they wanted to get. They got everything else put into the bill. We also have, again, I mentioned that KJA had some requested language that was put in. Cabinet had quite a few requested changes into the bill. Those were put in. We've also had the Ombudsman Office, which requested to have some oversight over a lot of these facilities, and so they've been included as well. It's been a labor of love, but we've gotten this bill to this point. I think it passed the Senate with a vote of 30-2, and we're hopeful for the same kind of consideration from this committee. I'm going to go ahead and pass the baton on here to my friends.
Senator, thank you. You've made my job easy. Obviously, this is your bill, and we've been privileged to work with you. Chairman Moser, Mark Lee, again, for the record, I've been working with all three of the associations, but particularly with and on behalf of Kentucky Senior Living Association. We appreciate the opportunity to highlight the bill. As I said, the Senator has done an awesome job of already doing that. As he said, this modernizes our model and aligns it with really the rest of the country. Right now, we have a pure social model and are sort of the last state to have that. And currently, assisted living providers are not able to deliver even the most basic of health service, such as clipping toenails, communicating directly with the doctor's office to convey a concern, communicating anything more than the bare facts to family members. This fixes that. And over the years, people coming into assisted living have, largely because of better choices to support them while they remain in their homes, they've been coming into assisted living communities much further down the pike, less well, needier in terms of care, and in Kentucky, we've not been able to step up the care provided, been very limited. Senator already mentioned consumer confusion and how this fixes that by merging private pay personal care with private pay assisted living. It adds the assurance of someone who's in end-of-life stage that has been in a licensed personal care building to be able to stay, even if they go somewhat past the normal ambulatory criteria for assisted living, if they're receiving hospice or other end-of-life services. That's a dignity issue. In addition to what Senator Alvarado said about aligning with the 2019 General Assembly Task Force, the bill's just a vast improvement over current statutes, both assisted living and personal care, especially as they relate to secure dementia units. a community with a memory care unit will be licensed as assisted living community with dementia care, and that brings with it delivery of health services within a memory care unit as a requirement. The bill increases required staff training for those working on such a secure dementia care unit. The bill also, for the first time in the 22 years that assisted living has been a recognized level of care in Kentucky, makes the 25 resident rights set forth in KRS Chapter 216-515 applicable to assisted living residents. Senate Bill 11 also places assisted living communities, again, for the first time, within the jurisdiction of the Office of the Ombudsman. And as the senator said, this bill updates assisted living, not its payor source, so it will continue to be a private pay, consumer-driven, non-institutional model. Thank you to Senator Alvarado for sponsoring this important bill, and to the many people who have worked with me and the senator on this bill, and to the committee, we appreciate the opportunity to speak on its behalf.
I'll make a motion on the bill.
We have a motion and a second. I do have some questions that we'll consider. Representative Dotson.
Real quickly, I think this is a great bill. The only concern I have in speaking with some constituents is that the social model, I know, gets grandfathered in, but rather than have the social model under the OIG rather than Dale, is there a possible way to leave it as it is as compared to bringing it under the Office of the OIG?
Representative Dotson, thank you for that good question. This isn't the first time that I've heard it, and ultimately, Senate Bill 11 does not address anything other than that's the choice of the cabinet. Our assumption from conversations with everyone from Secretary Friedlander to the Inspector General, et cetera, our assumption, even though it hasn't been expressly stated, is that because under this bill, basic health services similar to what is currently allowed in licensed personal care will likely be within the purview of OIG, simply because now sort of that line of delineation between the Department for Aging and Independent Living and OIG is whether there are health services involved. Because this would allow a provider to layer on those health services should they choose, in addition to the social model. We would just expect that likely the decision of the cabinet would be for all of this to be within the purview of OIG, but that's their choice. This bill does not directly address that.
Thank you.
Thank you.
Representative Birch.
What is this, as I understand it, this is for per pay patients, is this true?
Private pay, yes.
And the cabinet has no problem with it?
They did not testify in the interim joint committee meeting. They did not testify before Senate Health and Welfare. And to the best of my knowledge, they're not here today. The essence of our conversations with the cabinet over an extended period of time, they had numerous requests. We had baked a lot of those into the bill that was pre-filed by Senator Alvarado. The Senate committee sub put more in as we continued to talk with them after toward the end of the interim. And there were only 3 issues that I can recall that they said, we'd like this. At the end of the day, we just said we can't quite get there. And Inspector General indicated to me that to the best of his knowledge, they would not be here to testify. He didn't use he didn't characterize an official position, but I think that may speak for itself.
Well, silence is bliss, right?
It can be, yes, sir.
This does set up a different standard for nursing homes. Is that correct? It elevates this assisted living somewhat.
It
From
can.
what it was. Does this mean there's additional cost involved to this here? But
That'll be completely up to the provider. So if the providers want to provide some of those basic services, they can. If they want to stay in a social model and not offer them, they can. They can stay in the same model that they offer now. If they offer some, and we're seeing more of them starting to do that. So if you're in some of these facilities, they'll have a nurse that might be on duty that might help with medications, or like something as simple as, again, clipping nails or doing some basic drawing labs for somebody to let them stay where they're living currently. They'll be now under OIG, or Office of the Inspector General, for review. But if you want to stay in a completely social model, you're perfectly allowed to do that. So it'll be up to the provider as to how much they want to provide, and then the Nurse Practice Act will kick in as far as that they have nurses available, and people will have to meet those regulations that are currently already in state law.
okay, thank you. Thank you, Madam Chair.
Representative Wilner.
Thank you, Madam Chair, and thank you, Chairman Alvarado, for the bill. It was a privilege to serve on the Alzheimer's and other dementia workforce development task force with you a couple of interims ago. As you know, I mentioned in that task force, this issue is deeply personal for me. My beautiful, brilliant father, who was in full-time medical practice at the time, was struck with early onset dementia, had Lewy body disease, 16 years. For the first 12, my mother, with help from family, we were able to care for him in the home. It was tragic because he was so bright, understood what was happening to him until he didn't. And when he eventually, his care became too much for my mother and for us to handle, we went to a number of different care facilities where they were told, we have a memory unit, we have expertise in Alzheimer's, and again, that turned out not to be the case. One facility, I remember getting a call in the middle of the night, you need to come get your father right now, he's wandering. Well, that's what patients with dementia do when they're in the late stages. So all of that, and as you guys know, I don't generally engage in a lot of personal stories on the floor in committee, but we had numerous experiences in nursing homes that offered specifically dementia care, memory care, specialty, and they were not equipped. It was very disruptive to our family. It was very disruptive to him. And I know, and I'm telling this story because I know this applies to so many other Kentuckians that we're trying to help. And so I guess my concern is if the agencies that are already in business and we let them step up to this, as I understand it, step up to this new level of licensure that says we have the expertise to deal with this, but they're not required to have any additional training. They're, not given any, they're just grandfathered in. My concern is that families will continue to have the kind of really terrible experience that my family did. And so what can you do to assure me, assure other families who may be faced with this, that these organizations who do say they provide dementia care, they do provide memory care, are actually going to develop new skills in order to do it properly?
And thank you for that question. I mean, obviously, this is what I practice in anymore full time. We know that the more disruption there is for patients, the higher their likelihood of having breakthrough behaviors, particularly with dementia. The more you can keep somebody in their environment, the better off they are. So I know during COVID, as COVID broke out in a lot of facilities, a person with dementia got moved from one room to another to create an isolation area for patients with COVID. Just that move down the hall to another location triggered them. A lot of behavioral issues. I got a lot of phone calls during that time. It was difficult. So if you can keep somebody and let them age in place, is what we say. So a lot of these facilities will often offer areas that are kind of memory care units, and then other areas that might be more for people that don't require that. The less of that movement that you have to have for somebody to go to another facility, because right now if they become difficult, they have to be sent to a nursing home or to the hospital, and all that triggers a lot of behavior and a lot of difficulties for folks. So the first thing I think we can talk about is that the more you can keep them in one location, the better off they're going to do as far as less disruption. And then as far as the training, I'm going to let our friends kind of address that issue.
Thank you, Senator. Just to piggyback on what Senator Alvarado said, the operating requirements, the operating statutory mandates and regulations after they transition on the license are identical, whether you are a new provider, a new applicant, or an existing building that may have been operating with the full blessing of the cabinet, may have been operating for 5, 10, 15 years, one of these secure dementia care units. They will have to comply with the same regulations and be inspected on the same basis. The only difference, when we talk about grandfathering, I want to be really clear, the only difference is a recognition that if someone holds that license, or in the case of assisted living, certification, that authority granted by the state of Kentucky to operate one of these, that means they met the criteria for obtaining that, okay? And they have continued to meet the criteria through the regular ongoing inspections. And so we looked at the issue and said, we want to raise the bar. We followed the lead of Minnesota in a statute that the Alzheimer's held up as, I don't remember if these were their words, but sort of the gold standard for these kinds of units. But we made it applicable to new licensees. And the reason for that is simply because my understanding is when you all say increase training requirements for a new cosmetologist to be licensed, and it goes from, I don't know, 100 hours to 120 hours. I've never seen you all say, oh, and by the way, existing cosmetologists have to essentially surrender that license and go back and get the additional 20 hours and then come back and reapply. But of course, if the operating requirements for operating, for holding that license change, they have to comply with that. That's all we did with this bill. That's what we did. Hopefully that answers your question, Representative. And on training, sorry, thought I was wrapped up. On training, this significantly, and this is in those regs going forward, post-licensure, significantly increases training required for people who work on that unit, and it really, really addresses and increases those who are in charge of that unit. But even the rank and file people, it's a sea change on training requirements. And without this bill, we would continue to have in Kentucky, authorized by the state, dementia care units that are assisted living social model where they can't relate directly with that person's healthcare practitioner, and others in licensed personal care where they do. And it's incredibly confusing, and that was a key issue, a key problem, as you well know, that was pointed out that it needed to be fixed in the report from the 2019 task force. Thank you.
Thank you.
Okay. Thank you so much for that explanation, because I have received some questions too about the grandfathering in of the existing assisted living. So I very much appreciate that. I think it was very thorough, and I know how hard all of the stakeholders have worked on this bill. I really appreciate all of the work. I've had a lot of conversations about this. I really appreciate the work that you've done with the Alzheimer's Association as well. I know that they had quite a few questions and recommendations, and I know that you've gone to great lengths to really accommodate the association. We do have one more question, and then we have two guests who would like to speak on the bill. Representative Sheldon.
Yes, Senator Alvarado, appreciate you. We're used to you bringing great legislation through here, so appreciate it. I'm not going to disrespect the process I got some stuff from the Kentucky State Board of Pharmacy just like yesterday. If it's okay, I'm just going to forward some of this on to you. They're very minor technical issues dealing with the medication management, medication setup kind of thing, and some of the definitions, if that's okay.
Yeah, that'd be great. I spoke with them yesterday. They sent it to me as well, so
Okay.
I'm familiar, and I think we're going to be okay, but I don't think anything's required, but they just wanted some clarification.
Yeah, that's kind of the way I felt. Thank you very much.
Thank you.
Okay, thank you very much. At this time, I'd like to invite Mackenzie Longoria and Sherry Culp to come to the table to give you each, if we can keep it to, Sherry is remote. Thank you for joining us. If we can keep your testimony to, 3-4 minutes, I would appreciate it. Thank you.
Thank you, Madam Chair, and yes, I will be brief today. Very quickly, also want to note thank you to many members here
Could
today.
you please introduce yourself for the record?
So sorry.
Thank you.
My name is Mackenzie Longoria, Director of Public Policy for the Alzheimer's Association. It's our Advocacy Day today, so thank you. Many of you stopped by today and are wearing purple, so we really appreciate it. Just wanted to give a quick thank you for those of you who did that. Chairwoman Mosier and members of the committee, thank you for allowing me to speak today regarding this piece of legislation. It is my job to speak on behalf of 255,000 Kentuckians that are impacted by dementia and their caregivers throughout the Commonwealth. I really want to state at the outset of my testimony that the concerns held by the association are, have been, and remain with members that represent the industry behind this piece of legislation. I also want to state that we are supportive of many, many, many aspects of this bill, and it is still our hope to find a viable solution. Since this major restructuring to the assisted living in Kentucky was first discussed and proposed, the association has worked in good faith to seek changes for 3 critical areas. Very respectfully, there were not a list of 20 demands. There has been a concern over 3 primary areas. Since the beginning of the development in the legislation in early 2020, the association has clearly communicated the importance of addressing these 3 areas. And I'm very happy to say that one of those areas was addressed early on through great conversations with the entities involved, and one issue remains outstanding. However, that issue is an area of grave concern for the association. The issue still outstanding is in relation to existing facilities being grandfathered into this new licensure category, what we just heard about. Unfortunately, the industry has not worked with us in several months, and they have not communicated with me despite a desire to find a comparable solution to this issue. Section 14 of the bill lays out the requirements for providers applying for the assisted living community with dementia care license, and I want to read directly here because the language is very important. Quote, "The Cabinet shall consider the following criteria for licensure, including, but not limited to, the education and experience of the applicant or its principals in managing residents with dementia or other dementia illnesses and disorders, and B, the compliance history." End quote. This section represents some of the best practices of the association. They were correct in that. But these critical sections apply only to new facilities, and this section was not present in the Minnesota bill that is frequently referenced. Facilities, existing dementia units in operation as of the effective date of this act, as well as those who may open their doors between now and July, are grandfathered into this newly created licensure system without having to meet these important education and experience requirements. I want to take a moment and address some of the arguments that have been presented in support of this clause remaining in the bill. It has been stated that we don't want to take away anything that these facilities are already in possession of. I'm an attorney by background, and I absolutely understand this notion. However, as receptive as we are to that, we are not taking away anything that these facilities already possess, as the license does not yet exist. Further, we are not taking their current certification or licensure, asking them to do X, Y, and Z, and then returning the same certificate or license. We are simply asking them to adhere to newly created standards in order to qualify for a newly created category of licensure. It has also been stated that many of these facilities have been providing dementia care for years and should be able to continue to do so. The association couldn't agree more. We want people who provide care to this complex population to continue to do so, but we want to help them in being able to provide that care by requiring adherence to basic standards. These facilities have had no guiding statutes or regs on what the provision of dementia care or memory care entails, and so it has been a piecemeal facility by facility approach. Further, in nearly every other licensed or professional occupation or setting, from nail technicians to physicians, we still require people to recertify, renew, and re-educate themselves on topics that they deal with every single day. Asking existing facilities to do the same is what we expect of these other professional settings. Finally, it has been said that this is a minor concern and will have minimal impact. I would perhaps agree if we were only talking about a handful of facilities. But this grandfather provision would mean more than 50 assisted living facilities and almost 90 personal care homes would be moved into this new category. That's almost 150 out of 304 active facilities. And with more, again, that could open their doors between now and July, as we know many of these facilities halted opening during the pandemic. That is why it is crucial for all facilities to be subject for the same requirements for this category. If we're doing an overhaul of a system, let's level the playing field. It remains our goal and our desire to support this bill once this important issue has been addressed. But until that change is made, we have to respectfully oppose the bill. Senate Bill 11 has many provisions that will improve our current assisted living structure. I can't say that enough. And the Alzheimer's Association commends the legislators who have worked diligently to improve this care setting for people living with dementia. Thank you.
Thank you. Representative Marzion, do you have a question?
I do, Madam Chair. Thank you for that testimony, Mackenzie. How many, you said there could be upwards of 150 or so, how many people are in these facilities, or can you hazard a guess?
It really varies. Some facilities are quite large, some facilities are small, 20 beds or less.
Thank you.
Okay. Next, we have Sherry Culp online. If you would like to make just a few comments, welcome.
Thank you so much. Chairman and members of the House Health and Family Service Committee, thank you for allowing me to speak today. My name is Sherry Culp, and I'm the State Long-Term Care Ombudsman, and I'm here today as an advocate for residents and consumers of long-term care facilities with concerns about Senate Bill 11. Long-term care ombudsmen are authorized and defined by the Older Americans Act as advocates for folks who live in long-term care facilities. We regularly visit the residents in Kentucky's current licensed long-term care facilities, and we help them solve problems with their care and services. We work to prevent abuse and neglect, and we help residents exercise their rights. Our mission is to improve the quality of care. Senate Bill 11 calls for making assisted living a new level of licensed long-term care. The bill also allows existing personal care homes to convert to licensed assisted living. While Kentucky does need to modernize assisted living, this bill does not do enough to protect residents from poor care, abuse, and harm. As written, assisted living facilities would be inspected about every 2 years. The Ombudsman Program recommends that assisted living facilities be inspected on the same type of annual schedule that other long-term care facilities are inspected on. In addition, the bill exempts assisted living facilities from Type A and Type B citations, which are used when residents experience abuse, harm, and neglect. This also limits citations to no more than $500. The Long-Term Care Ombudsman Program recommends assisted living facilities not be exempt from Type A and Type B citations, and their penalties not be capped at $500. Kentucky must be able to hold all long-term care facilities accountable for harm and abuse. We're also concerned about the issue that Ms. Longoria from the Alzheimer's Association mentioned, and I won't belabor that, but grandfathering some facilities into this new licensure level of care would have them be exempt from certain initial requirements. Every facility converting to this new licensure needs to meet the same requirements. It needs to be confirmed that they have the knowledge and the skills to provide dementia health care, since they are moving from a social model to licensed healthcare facility. I just thank you so much for allowing me to share with you today. Thank you.
Thank you. I really appreciate your comments and your being here today. And we have talked a great deal about the grandfathering issue, and it was my understanding that for the facilities who would be grandfathered in, that if they were required to stop taking care of patients, they would lose their license during that period of time to get up to code, but moving forward, they will be responsible for meeting the same qualifications. So I think that it's important that the facilities who are providing care to their patients now not have to have a gap in services. So that was my understanding. I know that we've really belabored this point. Hopefully, if there's still questions, there is room to work out those differences. So thank you very much. We do have a motion and a second on the bill. Representative Marzian, did you have one more question?
I have another question, Madam Secretary, Madam Chair. So my question, I guess, is to Senator Alvarado and that group. Why have they exempted or the inspections just every 2 years, and could there be a compromise and grandfather the folks in and let them keep their licenses as they work on their licensure requirements? Because I think all of us are really worried about our vulnerable elderly people, our vulnerable folks with dementia. And we're all going to be there one day, so I want to make sure folks are really well taken care of. So is there a way to do that we could not grandfather them in, have them do the same requirements, but keep their license, or keep not make them discharge all of their folks? Thank you.
Yeah, I think as far as the 12 to 24 months, I think if they fail an inspection, they're required to do them more often. And if they're good partners and they've done well with their inspection, then we got them out to 24 months. I think there's some national statistics you might be able to quote on that. But that's how we achieve that, so that if someone does a good job, they can go out 24 months. If they fail, they're going to have a review done much sooner in that regard. Maybe you can address the issue with the licensing and all that.
Certainly. Nationwide, the average for assisted living relicensure inspections, the regular inspections, is 19 months. There's a handful of states that the one that's farthest out there is 60 months. As a provider, it made no sense to me. I want my buildings and frankly my competition to be assessed more frequently. Even the best providers, knowing that somebody's taking a look. That's not a bad thing. It's not a bad thing, even when you're motivated to give the best care possible. To speak to what Senator Alvarado said, Senate Bill 11 says if you've had a significant citation or violation in the preceding survey, then the state will come back in 12 months. If you've had a very good survey, 24 months. Keep in mind, Representative Marzian, that the cabinet has now and will continue to have under this bill the authority to come in at any point in time that there's a credible complaint, and also when there's been a significant citation, a significant deficiency, the state can come back in and verify that the corrections the facility says it has made were timely made. And if they have question, they can come back again and make sure that they're not being fed incorrect information. So I would suggest that it strikes a balance. It in a sense, honors those good providers. It focuses the not unlimited resources of the cabinet on the ones that have had some difficulty. And again, there's certainly no less authority of the cabinet to go in and to, as necessary, sanction and go after someone's license.
And then my follow-up, is there room for wiggle room to not grandfather, even though it may take them a little while, let them keep their people, but let them also adhere to the rules that you have for folks coming on after July 1?
I don't know that there is. I mean, this has been worked on. This has been pre-filed since October. We've had this bill out there. I mean, what I've told a lot of the folks that are saying we want to get this changed is either they can have this bill or they may not get one at all. So the alternatives we have is, I think, the bill that is before us and the way it's been drafted with all of the input that's been received, or we just say we'll just keep going the way we are with the confusion that's out there and the concerns that are out there. We've made a lot of accommodations. And like I said, things that probably I personally would not have agreed to, but the stakeholders and the work group that's been at the core of this bill were willing to agree to. I want to remind everybody, this is not Medicare or Medicaid funded patients. None of this is state. These are all private dollars. So these are folks who, if I have my mom in a facility like this and I'm paying a lot of money per month, and it's a lot of money in private pay, and they're doing a lousy job, tomorrow I show up and I move my mom and I go somewhere else where I'll pay my good earned money to somebody else. So the ultimate arbiter of good care are the people that are paying for these services. It's not the state, it's not Medicare, there is no public money coming to this at all. We're injecting now with people like the Ombudsman Agency, which is frankly a federally required agency of oversight, to the state to oversee private pay model care, which I have a bit of a concern with, especially when we have no oversight over the Ombudsman Agency. The state of Kentucky can do nothing. If you have a complaint, you have to go to the federal government to file that complaint and have those issues. But we're giving an agency oversight over private pay facilities. Again, I wouldn't have agreed to that. The stakeholders have agreed to that. I'm willing to go with that to get this bill to the point that it's gotten. So a lot of things have been accomplished at this point. I think what we have before us is the bill that I'm willing to consider. The other option is to say just scrap it and we go back to square one where we're at, which I don't think is a good place. I think we need to modernize this. Everybody wants to eat the apple all in one bite. At some point, if public monies become involved in this, there'll be other discussions to be had, I'm sure, with those kinds of considerations.
Okay, thank you so much. Representative Sheldon, do you have a very quick question?
Very quick. Just want to make sure I understand it. Of the ones that are being grandfathered in, they're not asking to go up in some kind of level of care, like from like personal care up to skilled care up to. I mean, that's not what this is, right? I mean, it doesn't.
Representative, the licensed personal care buildings that have secure dementia care units, and I don't have the stats in front of me, right, but you've heard the number 90. Mm-hmm. I don't believe that that's a correct number. Okay. There may be 90 licensed personal care buildings that fall under this, but they don't all have secure dementia care units, I don't believe. But in any event, they will, in terms of level of care, those secure dementia care units, those buildings are essentially a lateral.
Yeah.
Okay? Mm-hmm. Now, the assisted living part of this, yes, they're going from being a social model where people who can't articulate, generally speaking, can't articulate their own needs. If they're in a secure dementia care unit, they're not usually going to be able to have the conversation with their physician that really needs to be had. And that's the reason why this bill says we're not going to have any more social model secure dementia care units. We're going to say, you have a choice in your general population, folks that don't live on those kinds of units. You have your choice as to whether or not to add those basic health services. As a provider, you have that choice. But if you have existing building or new building, if you have a secure dementia care unit, you will offer basic health services. Your staff will be able to be the advocate, the expresser of the needs of that resident who can't communicate for themselves with their own care practitioner.
I got you. So you provided. Thank you very much.
Thank you.
We have 3 other bills to consider, and we have 45 minutes. So I think that we are good on questions. Secretary, please take the roll.
Representative Bentley. Representative Bowling.
Yes.
Representative Bray.
Yes.
Representative Birch. Representative Dodson.
Yes.
Representative Elliott. Representative Fleming. Representative Fraser Gordon. Representative Marzian.
Yes, and briefly explain my vote. I'd like you to come visit me again, and we can talk about this, about maybe an amendment. Thank you. Yes.
Representative Gibbons Prunty.
Yes.
Representative Rayburn.
Yes.
Representative Raymond.
Yes.
Representative Riley. Representative Sharp.
Aye.
Representative Sheldon.
Yes.
Representative Tate.
Yes.
Representative Weber. Representative Westrom. Representative Wilner.
Yes, but with some concerns and reservations.
Chairwoman Mosier.
Yes, ma'am. Okay, Senate Bill 11 passes with favorable expression. The same should pass on the House. Thank you very, very much for your great presentation and all the work.
Thank you, Madam Chair, members of the committee. Thank you.
Thank you. Okay. Oops, what did I do with my... Okay, next we will take up House Bill 512. I know that Representative Meade is here. Sorry about that. And please introduce any guests and proceed. And we do have a committee sub. Is that correct? So
Motion on sub.
Second. We have a motion and a second on the sub. All in favor? Any opposed? Okay, we are working from the sub then. Thank you.
Thank you, Madam Chairman. I am David Meade, Speaker Pro Tem of the House, and I'll allow my guests to introduce themselves.
Hi, I'm Dr. Patricia Grodecki, and I'm a board member for the American College of Cardiology and representing both the American Heart Association as well as the American College of Cardiology.
Good afternoon, Mike Pointer. I'm the Executive Director for the Board of Emergency Medical Services.
Well, thank you, Madam Chair, members of the committee. House Bill 512 is an act relating to heart attack response. And what we are doing is requiring the Department of Public Health to designate licensed hospitals as Level 1 comprehensive cardiac centers, Level 2 primary heart attack centers, and Level 3 acute heart attack ready hospitals. We're also amending statute to expand the protocols of emergency medical services provide including the providers to include trauma, cardiac arrest, and heart attack. One of the three most time-sensitive emergencies is, of course, heart attack. And of trauma, stroke, and heart attack treated and transported by EMS, only heart attack doesn't have designation legislation in Kentucky. So this legislation is similar to what we did with stroke legislation in 2010. And with Kentucky being one of the states leading the nation in heart attack and heart disease, this bill is simply about improving the quality of care and saving lives. Right now, there are currently 27 certified and accredited heart attack centers here in Kentucky. And as I said, we're trying to make this similar legislation to the stroke legislation in 2010. And in 2008, there were 6 certified stroke centers in Kentucky. Since that bill passed in 2010, there are now 41. And due to that, hospital mortality has decreased from 11.7% to 3.6%. And being discharged to home has increased from 28.4% to 48%. This legislation came as part of the Kentucky Heart Disease Stroke Prevention Task Force, which is made up of the American Heart Association, Cardiologists Association, the Cabinet of Health and Family Services, American Association of Critical Care Nurses, Preventive Cardiovascular Nurses Association, and the American Association of Heart Failure Nurses. This is a federally funded task force, and for the past 6 years, this has been one of their top recommendations. So, Madam Chair, that's really what the bill does, and I would...
Second.
Thank you. We have a motion and a second. We do have 2 individuals online, Dr. D.P. Suresh and Alexander Kuhn are online. Do we have any questions from the committee? All right. Well, seeing none, is there anything that you'd like to add in a very short 30-second snippet?
Would you like to say that?
Well, I think most impressively is that the only other 2 states that have higher mortality rates from coronary artery disease and heart attacks is Mississippi and Arkansas. So that's where we're at with this. Time is muscle. Another statistic that we have in the Commonwealth is that typically from the minute a patient reaches our hospital door to the time that we open that artery, by the American College of Cardiology and the American Heart Association standard, it's 30 minutes. It's 52 in the Commonwealth.
Okay. Thank you so much. I appreciate that. And I appreciate the brevity. Secretary, please take the roll.
Representative Bentley? Representative Bowling?
Yes.
Representative Bray?
Yes.
Representative Birch? Representative Dotson?
Yes.
Representative Elliott? Representative Fleming? Representative Fraser Gordon? Representative Marzian? Representative Gibbons Prunty?
Yes.
Representative Rayburn?
Yes.
Representative Raymond?
Yes.
Representative Riley? Representative Sharp?
Yes.
Representative Sheldon?
Yes.
Representative Tate?
Yes.
Representative Weber? Representative Westrom? Representative Wilner?
Yes.
Chairwoman Mosier?
Yes, ma'am. House Bill 512 passes as amended by the committee sub with favorable expressions. Same should pass on the House. Thank you very much for being here. Congratulations.
Well, thank you, Madam Chair, members of the committee. And even though Dr. Suresh and Alex didn't get to speak, I want to just say I appreciate them being there for the support.
Yes, thanks very much to both of you for taking the time to be here and being available for any questions. Next, we will take up House Bill 529. If everyone can please introduce yourselves for the record and proceed. And we do have a committee sub.
Second.
We have a motion and a sub and a second. All in favor of adopting the sub? Aye. Any opposed? Okay, we have adopted the sub. Thank you.
Thank you, Chairwoman Moser and committee. Such a distinguished and awesome-looking group of people. Look forward to presenting this bill today. Thank you for your time. Today, we're going to be talking about a compassionate patient support bill. This is a bill that the medical community has brought to the forefront as a need for patient support. My name is Killian Timney. I'm the representative from the 45th District, and I'm going to let my two co-presenters introduce them.
I'm Phil Bernard. I'm a pediatric intensive
Will you
care.
turn your microphone on, please?
Just push them.
Thank you so much.
No worries. I'm Phil Bernard. I'm a pediatric intensive care unit physician. I'm also the University of Kentucky Chief Medical Information Officer.
I'm Dr. David Danhauer. By training, I'm a pediatrician, but I'm also a Chief Medical Information Officer at Owensboro Health.
We also have
Online,
Dr. Arnold.
yes, thank you so much. Dr. Suzanne Arnold is online. Thank you so much for being with us. If you'd like to introduce yourself for the record, and then I'll have Representative Timney go ahead and present.
So my name is Dr. Suzanne Arnold, and I am a medical oncologist, professor of medicine at the University of Kentucky, and the Associate Director of Clinical Translation at the Markey Cancer Center.
Thank you so much.
Good afternoon.
And I would like to thank these presenters here also for their expert testimony today. I feel like we're in the 2-minute drill, so we'll get right to it. This bill creates a mandate for doctors that they must review, interpret, and release critical medical information, specifically certain tests, within 72 hours after receiving the results. And I would like to kind of hand off to give a reason why this bill is necessary.
I really appreciate you having us here today. Thank you, Madam Chairman, or Chairwoman. The University of Kentucky, I'm a Chief Medical Information Officer. My primary goal is to make sure that information comes to physicians and patients in an organized and usable manner. Well before the 21st Century Cures Act was enacted, we put forth open notes at the University of Kentucky, as well as my partners throughout the state. We believe that patients own their data and have every right to access their data in any way that they feel necessary. The 21st Century Cures Act was passed, and it codified the fact that people own their own medical data. We're fully in support of that, and frankly, have been petitioning for that for many years. However, one of the unintended consequences of the 21st Century Cures Act is that patients now receive their results prior to their physicians and their clinicians. You can see that this causes a lot of angst amongst our patients, and it removes the patient-physician relationship where we're a trusted advisor and counselor and give people hope in the times that they need it the most. We are asking for a very specific, limited exemption to give our physicians and our clinicians 72 hours on tests that have a realistic, meaningful chance of having bad or tragic news. So that way the physician can present the information to their patients in an organized manner, interpret those results, and give them hope when there's hope, and prevent patients from having undue anxiety and, frankly, misinterpreting results. Now, this is very personal to me also. And if you go out to any of your colleagues or your physicians, they will tell you stories about people receiving results on a Friday afternoon, not knowing what it meant, misinterpreting those results, and frankly, having tragic outcomes in some cases that Dr. Arnold can elude more.
Motion on the bill.
Second.
Okay, we have a motion and a second. We do have one question. Representative Raymond.
Thank you. Can you all explain to me what it means after the results are finalized? My fear was that 72 hours could go by, then the patient receives them in their medical record, and then it's still several days until they connect with their doctor on it.
Yes, ma'am. So we're Chief Medical Information Officers, so finalize is an important way for us to operationalize the material. So there's a preliminary reading on most pathology and radiology, and then it's finalized after the physician can really look at the information. Generally, that's within a 12 to 24-hour period. But it's very important not just to give them the first impression, but to give them the actual final result.
Okay. Thank you. Thanks very much for your presentation. Seeing no further questions. Oh, I'm so sorry. Representative Marzian.
I just have a real quick question. And I think you might have answered, I might have found the answer, but when I go and get labs drawn on my routine, I have my chart, and I can go in the very next day and look at them. So that would still not prevent me from doing that?
We've cut out a very specific group of results, specifically pathology and radiology and genetic testing, that has a high likelihood of delivering bad news.
That's
You'll
great.
still get your lipids.
Yeah, I love to look at my labs, and I'm a nurse, so I know what they mean. So
Right. And I think that's what we're concerned about is we want that information out there, but please give providers time to think, plan, and have a great conversation that we're losing right now. Our providers are not having that critical conversation with patients when we're delivering not so much good news. And we want that relationship, patient-physician relationship maintained. And that's what we're asking for today.
Thank you so much. I would agree that that relationship is so critical when you know that you'll have ongoing care with that patient and ongoing treatment. So thank you very much for bringing this bill. Secretary, please take the roll.
Representative Bentley?
Yes.
Representative Bowling?
Yes.
Representative Bray?
Yes.
Representative Birch?
Okay.
Representative Dotson?
Yes.
Representative Elliott? Representative Fleming? Representative Fraser Gordon? Representative Marzian?
yes, as long as I can still see my results the next day.
Representative Gibbons-Prunty?
Briefly explain my vote. As a recent survivor of breast cancer last fall, I totally appreciate this and appreciate you, Jack, coming here from Owensboro. My vote, yes.
Representative Rayburn?
Yes.
Representative Raymond?
Pass.
Representative Riley?
Yes.
Representative Sharp?
Yes.
Representative Sheldon?
Yes.
Representative Tate?
Yes.
Representative Weber? Representative Westrom?
I'd like to make a comment. I had 6 med students in my office this morning, and all 6 of them are thrilled to death by this bill, many of whom were raised in families that one of the parents or both were doctors, and they're really relieved about this. Thank you very much for bringing this bill before us, and I vote yes.
Representative Wilner?
Yes.
Chairwoman Mosier?
Yes. House Bill 529, as amended by the committee sub, passes with favorable expression. The same should pass on the House. Congratulations, and thank you very much for your work on this.
Thank you, committee, and thank you, Chairwoman.
Very much.
Okay. Next, we will have a discussion about House Bill 777. If everyone can please make their way to the table and introduce yourselves for the record and proceed. And we do have a committee sub to adopt.
Thanks.
I'll entertain a motion on the sub.
Motion on the sub.
We have a motion and a second. All in favor? Any opposed? Thank you. Please proceed.
Thank you, Madam Chair, and thank you, members of the committee. I'm Ken Fleming. I represent the 48th District in Jefferson County.
Do you mind pulling your microphone just a little bit closer?
I thought it was close enough.
Thank
okay,
you.
There's that better. We're excited that we're here today in terms of putting forth a 777, House Bill 777. Before I do that, I just want to introduce my guests, and we do have, I believe, I know one person on Zoom who's there to answer any questions. So, just introduce yourself.
Good afternoon. I'm Nancy Galvani, President of Kentucky Hospital Association.
Thank you, Madam Chair and members of the committee. J.D. Cheney, Kentucky League of Cities.
I also want to.
I'm sorry, Dr. Maria Brayman, are you online?
Yes, I am. Good afternoon, Madam Chair. I'm Dr. Maria Brayman. I'm Chief Medical Officer with Appalachian Regional Healthcare.
Thank you so much for being with us.
Thank you, Madam Chair and the committee members. We also have quite a few stakeholders behind us that are available to answer any questions you might have as we go through this. I do want to thank the committee and appreciate your patience and understanding as the 13 stakeholders work out many issues in terms of where we are with House Bill 777. That's right, 13 associations. Everybody or everyone working on the House Bill 77 is the best interest of patients in receiving the quality care, and that's our foremost focus in terms of going through this very long process. I can't tell you the number of hours, women and men's hours, that have gone into the final product of House Bill 777. I suspect probably north of 1,000 hours total that people put forth and having this come to fruition. Coordinating this issue, this bill, has not been an easy task. I'm sure some of y'all can attest to that, but it reflects the stakeholders and their being open-minded, the willingness to serve patients, and the determination to do the right thing. I want to just outline the 13 associations that were brought together in terms of working this out. Kentucky League of Cities, Kentucky Association of Firefighters, Kentucky Psychological Association and Advocacy Network, Kentucky Association of Counties, Kentucky Association of Healthcare Facilities, Kentucky Center of Assisted Living, Kentucky Hospital Association, Kentucky Board of Emergency Medical Services, Kentucky Community Technical College System, Kentucky Ambulance Provider Association, Kentucky Association of Public Safety of Communications Officials, and a Kentucky Emergency Numbers Association. And I hope you caught when I read all those associations' names out, each one started the word Kentucky, because that's who we are, because we are united we stand, or divided we fall. Let me cover the purpose of the bill. For many years in dealing with the transportation of patients between healthcare facilities has become a very sensitive and problematic issue without a whole lot of movement for the past several years, but this bill today helps answer some of that. At least it moves the ball forward to solving those issues. We're very mindful of how 911 calls are handled while addressing those calls that might not be classified as 911 but are time sensitive. I have many examples where patients were not transferred from one facility to another from either 8 hours or several days. Here are some of the main provisions of the bill. First, during our discussions, and there have been quite a few of them, we found many pertinent issues that needed to be addressed, but needed more time to study and debate them. Given this bill establishes a legislative task force to act during the interim to study delivery of EMS services, develop findings and recommendations, and then report back to the General Assembly. 2, it addresses patient outcomes and EMS delivery services. 3, currently the KBEAMS, or the Kentucky Board of Emergency Medical Services, operates under KCTCS. And this bill will establish KBEAMS as an independent agency of the state government. And with my experience with emerging companies and reorganizing businesses for profits, for not-for-profits and profits, my concern is always 2 things. 1, are we and how will we improve the product of the service? And then 2, taking care of the employees. And this bill, we believe, addresses the objective by having a very safe landing for personnel, handling the funds, equipment, records, and supplies while improving the quality of care. In addition to that, this bill also looks at the makeup of KBEAMS. 4, it provides the Cabinet of Health and Family Services complete access to all data and records maintained by KBEAMS and its contractors. By combining this data bank with a cabinet, better analysis of runs, coverage, types of calls, geographical reach, and many other factors will provide better measurements that will help regulations and service. 5, it reforms the EMS complaint process to make it easier for patients to register complaints and ensure the quality of ambulance service. 6, it involves a cabinet in investigation of certain complaints while leaving disciplinary enforcement to KBEAMS. 7, it reforms certain aspects of the Certificate of Need, or CON, to allow cities, counties, and hospitals to transport patients under certain conditions without a CON. 8, exempts organ procurement organizations' vehicles from speeding limits and traffic flows while transporting a human organ or issue for the purpose of organ recovery or transplantation in an emergency situation. And 9, it sets up the TAC committee and EMS, which my friend Republican Prunty pushed on the bill. With that, Madam Chairwoman, I'm going to ask KHA to talk, and then we'll have the Kentucky League Cities make their comments.
Thank you so much. Good afternoon, Chairwoman Mosier and members of the committee, and thank you for allowing us to speak today on the need for Representative Fleming's bill. For more than a year, KHA met with representatives of hospitals, long-term care providers, KBEAMS, and ambulance providers to find a solution to what we are seeing as a growing problem for transport. And as we explained, I think we testified in the interim to the Interim Joint Committee on Health, Welfare, and Family Services last August that hospitals across the state have been reporting to us that many times when they call, the ambulance would not come. And this has resulted in long delays in patients getting transported to the level of care that they need, and this has been a particular problem in rural areas. Our purpose in raising these issues is not to place blame on anyone. It's just really to outline a problem that's growing, to make you aware of that problem and the need for Representative Fleming's bill. House Bill 777 does not give all parties what they desire, but we feel it's an important first step to addressing the needs of our patients, and that's why we're here. The bill will provide a mechanism, as you have heard, to address some of the problems now, but to have further study through this legislative task force, to have additional data, to have additional discussions, to look at these issues further, and make recommendations back to the General Assembly. The problem we're seeking to address isn't a hospital problem, it's not an ambulance problem, it's not a local government problem, it's a patient problem. And I think we all understand that we just can't do things the way we've always done when people's lives and their health is in the balance. We at KHA really appreciate being part of the collective groups that came together. You've heard so many groups, so many hours. I'll attest to that. We're very proud that we were able to work out a solution to move this issue forward. KHA strongly supports House Bill 777. We want to thank Representative Fleming for his leadership on this issue. We look forward to working with the legislature and all parties to move this in the future forward to help our patients.
Thank you, Madam Chair and members of the committee. This is my first 20 years with the League of Cities, and I believe this is my first time before the Health and Welfare Committee. So,
welcome.
a little bit naive on certificate of needs. I tell you what, I've learned a whole lot in the past few weeks about the way that process works. But I do want to thank Representative Fleming, Representative Hart, and Chair Moser for the work that's occurred over the course of not only this session, but over the course of the past several years in this discussion on what could be controversial topics. You know, it's always better. You always end up with a better piece of policy if you have an opportunity to hear the perspective of so many different organizations. And in this instance, we talked to everybody. The Hospital Association worked with groups. We worked with groups with our fire chiefs and our firefighters who had expertise to bear on this issue. But I will agree completely with both Representative Fleming and Nancy with Galvani with the Hospital Association to say there is work to be done still. There always will be work to be done when it comes to taking care of your constituents from a patient perspective. That work will never, ever end. But there is work to be done and discussion to be done with regard to the way we certify personnel and look at the way we train through the K-Beams process. This legislation sets that up to be able to have an open dialogue and discussion related to the way that K-Beams functions in a way that our fire chiefs support, our firefighters support, our mayors support. It also addresses something that's near and dear to the city government heart, which is if you think about why city governments exist, it is to serve, and its most paramount objective is to serve the health and welfare of its constituents, of its citizens, to make their lives better, to be able to respond. And when it was brought to our board of directors that city governments and county governments, both, could not respond to their constituents without going through a lengthy CON process here in Frankfort, that was being blocked, and so they could not respond. And so my board put on our agenda to pursue legislation that would give us an exemption from the CON process. This bill addresses that right now. We got to be able to enable our local elected officials to serve their citizens, especially in situations like Prestonsburg, where my mayor testified from there, the mayor of Prestonsburg on my board of directors testified about hour-long waits. And you've heard all of those stories. And so frustrating for an elected city official to be able to tell their constituent, there's nothing I can do about that. So this legislation addresses that certificate of need process, and it empowers it and tackles it from a local government perspective. Local leaders know these needs. This is a sound bill with sound policy that moves this ball forward significantly for the citizens of the Commonwealth, protects our personnel that provide these services, and sets the stage for bigger discussions. And I can't more enthusiastically urge you to support passage of House Bill 777.
Thank you, JD. I appreciate your testimony. You can tell he's been around this for a while. He's very good. He notes in here. He articulates the thoughts and their needs and their situations quite well. I do want to call out just a couple people, but I can do a lot of that. One, I want to thank Representative Hart for his coordinating and helping out. Miss Donna Little from the KHA, and then I want to call out Chief Briscoe for what he and I had a lot of conversations, and I appreciate his open-mindedness and working with them so diligently. I just want to say that one thing, as we mentioned, that took a lot of coordinated effort and took a lot of time and effort. But I'll end with this. Where I began, is that each association begins with the word Kentucky. And this might be a little cliche, a little dorky, but I think it really says something, I think, about this group. It says, united we stand, because the divided we fall is not an option. And so I think we're united in terms of moving this ball forward and make Kentucky having a better ambulance service. So that, Madam Chair, thank you.
Thank you so much. I know that Dr. Maria Brayman is with us. I'd like to give you a couple of minutes to just say a few words, and then I know that we have some other folks who wanted to speak on the bill, and then we'll open it up to questions. Dr.
Thank you. Thank you very much, Madam Chair. I just want to echo the support for this bill, and I know all the work that many people in the room have put in to bring this forward. I'm here as an advocate on behalf of our patients in Eastern Kentucky. We represent 12 hospitals. We have several patients who unfortunately have experienced significant delays, longer than hours, up to days, as a result of the struggles we have right now. So this bill is very important in terms of supporting our patients in all the counties that we serve. Thank you.
Thank you so much. We do have with us Dr. Walt Lubbers and Dr. Ryan Stanton. If you have something that you'd like to add, if you can make your way to the table, I think you can. I don't know if we can make room for folks. Thank you.
Thank you, ma'am. My name is Walt Lubbers. I'm an EMS physician and the current state medical advisor for the Board of EMS.
Is your microphone on?
It is. I can bring it closer. Sorry.
Perfect. Thank you.
Yep. There we go. Better? Great. Thanks for the opportunity to say just a brief bit. I also represent the Kentucky EMS Association, which represents EMS professionals, so paramedics, EMTs, EMS physicians, flight nurses, etc., the folks that are out doing the work. We support the bill. We think it's a reasonable compromise on a whole lot of things. It provides good stability for letting the folks that know about EMS continue to regulate EMS, as well as a reasonable change to the complaint process. And it recognizes that we don't think we're done and that we can't walk away with this being the only EMS bill that any of us ever think of because there's still a lot of work to be done. So I think that legislative task force and the KBEAM special committee on it are super important and great parts of this bill. Our providers have asked us to add one small request, and that is, as things go through, possibly consider the addition of an EMS provider nominated by KEMSA for both the EMS, for the Board of EMS, as well as that task force to continue to represent EMS providers specifically. But otherwise, we again think this is a good bill and we support it. And I think with just a very small change, it can be even better. So thank you very much for your time.
Okay, thank you.
Madam Chair, thank you to all the representatives for the time today. My name is Ryan Stanton. I'm a board-certified emergency physician and board-certified EMS physician. Interestingly, with the specialty of EMS, you've got approximately 20% of the board-certified EMS physicians sitting at this table right now. This is a specialty, and this is a profession in which we continue to move the care of patients to where they are. And what this bill addresses is some very important things, and we do support the bill as it is written right now. And I do appreciate Representative Fleming being an open ear for us to help work through some of these issues. As we move forward, I think it's very important that we continue to separate the 911 service to ensure that our paramedics and EMS professionals are at the bedside as quickly as possible. In Lexington, where I'm the medical director, we're not satisfied with not being at a patient's bedside in 10 or 15 minutes. We look at 5 to 8 minutes as the time from that call drops. So I want somebody at that bedside on that street or wherever that patient is. So we need to continue to support that. We also need to separate out those private or whoever is doing interfacility transfers and also support the process for hospital-based EMS, as we would call it, transport services, to ensure that they can provide and transport those patients that need to be elsewhere. As we move forward, I would strongly encourage that the task force and those that work on the legislation and recommendations moving forward represent the specialty and profession of emergency medical services. This is not something that everybody can do. This is something that takes special focus, special education. Even for us, both of us at this table, being board certified in emergency medicine was not enough. and we felt it was necessary to continue to advance our education and training to be able to provide the best services for our paramedics, for our EMTs, and most importantly for our patients. So as we move forward, I strongly encourage to work closely with those professionals that are boots on the ground to provide the care for those across the Commonwealth and beyond. Thank you.
Thank you so much for being here. As a former flight nurse, I really appreciate the work that all of you do, everyone in this room. I understand the patient care that takes place and the needs of the patients, stabilization in the field. It's not an easy job. It's an exciting place to work sometimes, but it's also very stressful. And I just want to, again, thank everyone for all of your work on this. My job is to ensure that patients get the care that they need in the Commonwealth. And however that happens, we are facilitators of the process. And I just want to say a lot of work has gone into this. Donna Little, we could not have done this without you, and Deanne, thank you so much for your work on just making sure that we get the language right. So many voices were heard on this, and I just really appreciate all of the passion around this. And I do think that we need a huge whiteboard and a big flow chart to really understand exactly how this works in every county and every city, because I know it's different. And we really, in the task force, want to take some time to understand all of those needs. And I appreciate the work with KCO and KLC on helping us understand the needs of the cities and the counties. We do have a few more people who have signed up to speak. Jim Duke, are you here? And then I know that we have Judge Dan Mosley and Judge Mike Buchanan. We also have Paul Zarapata with KCTCS. I don't know if you were here just to answer questions or if you wanted to make a statement. Okay, thank you so much. Make yourselves comfortable and introduce yourselves for the record, and please proceed.
My name is Jim Duke. I'm with the Kentucky Ambulance Providers Association, and we're here today in support of House Bill 777. We've worked very closely with everyone over several months, going back into the committees that met last year, trying to acknowledge and figure out how to fix the patient transport problem. Just like our friends in the hospitals and in long-term care, we're experiencing one of the worst staffing shortages that we've seen in our career. That's been a big part of what we've had to deal with over the last 2 years. And that's an ongoing problem I think we can discuss in the committee. But we're here today to support this bill. We worked closely. Everybody did to try to come up with something that we all felt was moving forward on better patient care. And that's all I've got unless there's any questions. Thank you. And I want to thank Representative Moser and Representative Fleming for all the work and open-mindedness you all have had to help us facilitate, as you said, to make this work. Thank you.
Thank you. Okay.
Hi, thank you, Madam Chair. Dan Mosley, Harlan County Judge Executive. Thank you for giving us the opportunity to speak on this bill. I'm here today not to support or oppose, but to share some concerns about the bill. I believe that health care begins on the street, at the home, at the car wreck, and I appreciate Representative Fleming for working through this bill. There's been a lot of conversation, particularly over the last couple of weeks. Would ask that the Kentucky County Judge Executive Association have a seat at the table as the task force moves forward. When someone can't get transported from Harlan ARH to University of Kentucky Medical Center, the County Judge Executive is getting a lot of those calls. Dr. Bramman spoke to that. She's exactly right. This happens more times than it should. My concern is that because of the major shortage of personnel in this industry that we have, and we've had this going on for a long time, but it has been complicated throughout the course of the pandemic, that what's going to happen is that we're going to have folks that need transported to another facility by ambulance, And it is going to take away from people who are calling 911 that are already waiting sometimes 30 and 45 minutes up to an hour to get transported to a hospital when they're having a heart attack. There's such a shortage of personnel in this industry right now that this is a major crisis. We've been talking about it for a long time. I worry that, you know, a lot of the folks that were in this industry have transitioned out into work into hospitals. In 2021, out of 4,000 registered paramedics in Kentucky, only 1,200 responded to ground ambulance runs. That's 30%. If 30% of the physicians had showed up in the hospitals during the last year, where would we be? With this shortage, the further dilution of ambulance services, I'm afraid, will only further deplete response, particularly in rural Kentucky. We're taking a cup of water that isn't full, and we're pouring that water into other cups, making them less full. The ambulance has to get to the person that needs it in an emergency situation. There aren't enough people to do that right now. I think this warrants further policy evaluation. Why? And I hope we can be a part of that task force that looks at this and looks at the critical issue that we face. I hear it every day. Someone telling me a story about an ambulance that did not get to their home. And that's not just in Harlan County. That's in other counties as well, from judges across the state. We've talked about this in the Judges Association. The number one issue facing our communities is EMS, and it's very broad. It's a very broad situation. There are some that are county-ran ambulance services. There are some that's operated through a taxing district. There are some that are operated by a private ambulance service, and there are some that are operated by cities. But the common theme is the shortage of personnel that are working in this particular sector of emergency response, going out to take care of the folks that need it. Like I said, I agree with Dr. Brayman. We hear the same thing. The hospital-to-hospital transports are another major issue. We recognize that. We get that call too. All of these folks are our citizens. They all need our assistance. I'm afraid there will be unintended consequences with this particular bill. I would ask that we take a look at it further, we slow it down. Many of my constituents haven't even seen the bill. It came out Tuesday night. I know there's been previous versions that have been worked through, and I appreciate that. But many of our constituents have reached out to us with the Judges Association that have expressed concern this morning. The goal has to be what we can effectively do that improves the service to our citizens, not only those that are in the hospital, but those that are at home that need to call 911 and expect and deserve that that ambulance gets there to help them. Until we address the human shortage element in this industry, I'm afraid efforts like this will have unintended consequences. I'll end by saying, as a judge executive, knowing what exists on the local level in my county, it's my obligation to be here to explain that to you and inform you of my concerns on how it can impact my citizens. Thank you for the opportunity to do so.
Thank you. If I could just address a couple of your points before we move on to Judge Buchanan. I just want to reiterate that this is a starting point. This is solving a crisis right now, and we have the opportunity in this task force to really take on the more difficult issues and absolutely have you as your association represented in any further conversations.
Thank you.
The issue of staffing and retention, recruitment, training, that's a separate conversation. It isn't addressed in this bill. We fully recognize that staffing is an issue. We're having conversations, this is a budget year, about potentially having training dollars inserted into the budget. We know that we need to expand our pipeline of healthcare workers, including EMS and paramedics. So I appreciate your comments very much. Thank you for being here.
Thank you.
Judge Buchanan.
Thank you very much, Madam Chairman. I appreciate all the work that you and Representative Fleming and this committee has done along with all the people throughout the state. It's absolutely necessary to address these problems. I'm just here as one of those people that doesn't have that problem. And my concerns are reflective of Judge Mosley's as well. In Warren County, we've had 2 county judges in the last 60 years. And my predecessor, who left office in 1993, helped to broker a deal with the then City County Hospital, who ran the ambulance service, and lost a couple of $1 million every year. Brokered a deal with the newly formed City County Hospital Corporation, which now you would refer to as the Med Center Health. And that deal was that they would provide ambulance service to us, to our taxpayers, to our citizens for free, and they would do it in a much more professional and effective way for our citizens. They've done exactly that. They agreed to grow with the community. They had about 50 employees in 1994 when I took office. Now they have 100 employees in the ambulance service area. They have 13 ambulances that they run. They do an outstanding job. And their time for showing up on the scene is less than the state average. It runs 7 to 7.5 minutes. I think that's remarkable. That's their average time. Much of the time, it's much sooner than that. But my concerns are the staffing shortage, which Judge Mosley so well articulated. But this has been the first time. This isn't the first time we've had a staffing shortage, but we've continued to grow. The medical center actually teaches EMS classes and certifies different EMS for their own training and for their competing hospital as well. They teach nursing classes. They have the WKU nursing school there on campus at Medical Center. They also have the UK Medical School there on campus at Med Center Health. They're a growing entity that is doing a great job. For the past several years, I've had Greenview Hospital, who is the other hospital in our community, which is a good company with TriStar, and we're proud to have both hospitals in our community. But they keep insisting that the reason they're not doing as much business is because of the medical center has the ambulance service. So they want my support, and they've asked for a certificate of need on at least a couple of occasions and failed to show a need in Bowling Green and Warren County. But I believe this bill is going to give them the opportunity to just walk in and start competing with Medical Center and further deteriorate our ability to keep good personnel. If we can't have enough people to run all 13 ambulances right now, we're only going to have half as many people because they're going to split the available EMS personnel that exists today. During my period of time, since Medical Center took on this responsibility 42 years ago, they've saved my taxpayers maybe as much as $200 million. That's a lot of money for my size community. But I'm very appreciative of that. Now, if their competitor, or the way it looks like in this bill, that any hospital is exempt from a certificate of need and can just come in and open up an ambulance service, then we're going to end up with the whole thing just being cannibalized, and if the medical center refuses to continue at the level that they're doing because they have a competition, which they almost have to cut back, and then Greenview decides that they're going to just quit or demand public funding, then the county, not the city, the county would be required to provide a taxing district or provide the funding for the one or both of them. Now, as I came into office, my predecessor, who served on the city-county hospital and served on the eventual city-county hospital corporation, did so for the benefit of the taxpayers of Warren County. When he left office, he arranged that I sit on the medical center board as well, so that I can look after our ambulance service. I can see this going to cost my citizens a great deal of money. And there have been 2 people that have actually been the administrators of the medical center at Bowling Green. There have probably been 10 at Greenview Hospital. And each time they decide they want to do something because it looks like a competitive thing to do, they end up backing off with the next administrator.
We have a motion on the bill. Do we have a second? Second. Thank you very much for being here. I look forward to having your voice, certainly on the task force, and maybe filling everyone in on how to run a successful ambulance service. It sounds like you have a lot of experience. And, I will add and address one of your comments. A hospital still needs approval from the city in which it resides. Right. So the city and, if it's the county, has veto power over a CON application. So there's still a review process in place. I understand the issues in Warren County and Bowling Green.
All right.
I've heard lots about it.
Thank you.
And congratulations on your term as judge executive. I understand that you are finishing your term and retiring, so congratulations. And
thank you very much.
I'll just thank you for being here. Okay, we have a motion and a second. Do we have any questions? Representative Westrom? Thank you.
I've had the privilege of, last Saturday I sat next to an ambulance driver in a rural county for about an hour. And I learned why he went into the business, how much he was making, which was $10 an hour, what the competition is, who owns it, and it was really quite an eye-opening experience. And one night I returned a phone call to a flight ambulance driver. And he was a very interesting person to visit with and talk about his experience, the training. I understand that there's different types of trainings. Some is much more expensive now than it used to be, and when you're paid $10 an hour, it would be hard to pay off your education bill. But I hope we can bring in the trenches ambulance workers before us to share their experience and figure out how we can really blend this to make it work across communities and populations.
Thank you so much. Representative Rayburn.
I have several questions, but I know we're limited on time. My question's for Representative Fleming. Looking at the makeup of the task force members on pages 57 through 60, I noticed that the Kentucky professional firefighters were not included. Knowing that fire-based EMS systems are the biggest provider of EMS in the state, what was your reasoning in not including them, and would it be possible to include them?
The answer to the question is, yeah, they can be included.
Okay. One follow-up question, please. Will rural EMS services be expected and made to make non-emergency runs out of their jurisdiction?
Let's repeat that again, please.
Will rural EMS services be expected and made to make non-emergency runs out of their jurisdiction?
You want to answer that?
Not at all. I mean, nothing is changing the current K-beams regulations that apply to service areas. and when people can respond to a non-emergency in a different service area. We're not changing any of that.
Okay. Can I please ask one more question? I've got a lot of concerned EMS employees in my district, and they've sent me a ton of questions. Is it true that if this bill passes, will there only need to be one certified personnel on the ambulance? And if so, why?
That's not in the bill. Nothing changes the personnel for ambulances.
Okay, thank you.
Representative Prunty.
Just a comment. Thank you, Madam Chair. I just want to thank you, Representative Fleming, for including House Bill 151, the TAC. I know my constituent, Troy Walker, is the president of CAPA, and we've had many conversations, and he says that reimbursement is a big issue, and I believe that will help move the ball forward on that issue. So thank you.
Okay. Representative Bowling.
Thank you. A comment, maybe a question. We'll see where this goes. But when you're looking at hospitals, especially in rural areas, and, you know, I think in this bill right now, either the city government or the county government has the say on whether, you know, a hospital, you know, can provide that service or not. But a hospital in a rural area, it treats the entire county. And so even though it might just be located in the city, and I don't want to, you know, I don't know how we word it, I don't want to put something in place where, you know, we're not giving the city the ability to treat its citizens, but that hospital treats the entire county and sometimes an entire region. And so a decision that a city government can make would affect the county, would affect the citizens in the county. And, you know, I represent all the citizens in the county, so I do have a major concern on that, and I don't know how that's alleviated in this.
May I respond, Chairwoman? I appreciate that. I've heard that from some of the folks out in the hall before this meeting, and I'll tell you, both the judges here today, I have immense respect for both of those, especially Judge Buchanan, who's kind of the dean of the delegation of local government, even over cities. So, but Representative Boland, to address you directly, just to be abundantly clear about what the bill does. The only CON exemption that hospitals are going to be able to get, the exemption, one exemption, is to transport originating out of their hospital. The other provisions that we've heard concern expressed about is if a hospital is going to make an application for non-substantive review. And in that case, or as a barrier for a hospital to be able to get non-substantive review with the cabinet, they have to have the city or county government sign off in order to make that application. Otherwise, they're going through a normal CON process. Mm-hmm. But I think the misunderstanding that non-substantive review means that you're waltzing in, the hospital's going to waltz in and get their certificate of need, is probably a mischaracterization of the non-substantive review process. That's not how that works. So if the city or county, depending on where the hospital's located, makes a sign-off on that non-sub review process, you've got that hearing. In addition, after that process, as a practical matter, we had this vigorous discussion with the Hospital Association going through. As a practical matter, it's the city and county governments that control dispatch. You're not going to have a hospital. It would be imprudent for a hospital to make any kind of application and make any kind of investment in the infrastructure and personnel, which you can't find, without having some agreement with the local government as a practical matter prior to entering into that field. Because if they're not going to get dispatched at the end of the day, why would they want to make that investment? So I don't see this as a territorial battle that may be characterized. I don't think it is. I think in large part throughout the Commonwealth of Kentucky, city and county governments are working collaboratively together in the best interest of their constituency. And so I hate to see any kind of impression that it's a city v county issue on that. Most of this is a collaborative process.
Thank you so much. I couldn't agree more. We've worked hard to make sure that it is collaborative, and we'll have issues, I'm sure, to iron out as we go forward, and that's why we're very intentionally putting this task force in place. Representative Sheldon, do you have a quick comment?
Yeah, just quickly, I want to just take a little bit of exception to how I think somebody mentioned that it was rushed through. I kind of find that almost comical, since 4 years ago, I can remember many hours sitting in Chairwoman Moser's office late at night with stakeholders discussing this very issue, and then going down the hallway the following year with another whole different legislator that represented this thing. And it just year after year. So for 4 years, I've watched this. And I think this is a great first step for the Hospital Association to step in and to kind of be the foundation that we operate this task force on. And Chairman Moser and Representative Fleming, you guys have done a great job putting it together. And I just want to say it's been a long haul. And thank you very much. I'm looking forward to the next step. So thank you very much.
Thank you so much. All right, seeing no further questions, Madam Secretary, please take the roll.
Representative Bentley. Your microphone.
Microphone, please.
Microphone.
Oh, I'm sorry. My rural counties sometimes are a little more concerned when we're talking about large investments, so I'll vote yes to get more discussion on it.
Representative Bowling.
I'm going to vote no today. I too hope that there can be more discussion. I've got several concerns. Obviously, Judge Mosley's from Harlan County testified before us today, but it's not just him. I've had several other city and county officials reach out to me on this, so hopefully we can work through that.
Representative Bray.
Explain my vote, please.
Sure.
I'm a yes. So I represent Rockcastle County as one of mine, very rural county. We've got a great EMS service there, but they couldn't do inter-hospital transfers because they were losing money. So every time they were having to go to Lexington, they might be gone 6-8 hours a day, didn't have the personnel that they could justify that transfer. So the hospital back home went through the CON process. Extremely expensive, extremely needed, extremely time consuming. The local EMS was fully supportive, but they still had to go through all of those and check all those boxes. Meanwhile, the people were kind of suffering. So I'm a yes. I think this is a great first step. This bill's come a long way. I'm glad to see the task force there. So thank you all.
Thank you.
Representative Birch. Representative Dotson.
I'd like to explain my vote. I'm a yes vote to get it out of committee, but I reserve the right to dig a little further into this and speak with you, Representative Fleming. Thank you.
Representative Elliott.
May I explain my vote, and I apologize for missing the discussion. I had some other business to attend to. I'm going to vote yes today to move this forward. I think that the task force is a great idea, but I do have some concerns that this might shift costs to local governments, and those are the concerns that have been expressed to me by my county and by the EMS director there. So I'm going to vote yes to advance it, but I may very well oppose it on the floor. Thank you.
Representative Fleming. Representative Frazier Gordon. Representative Marzian. Representative Gibbons Prunty.
Yes.
Representative Rayburn.
No.
Representative Raymond.
Yes.
Representative Riley.
I'll briefly explain my vote. I completely understand the concerns that Judge Executive Buchanan had and the possible unintended consequences that could impact Warren County. I consider Judge Buchanan to be the gold standard of county judge executives in the state, and completely understand that part of it. I'm going to vote yes to get it out. Committee, I commend Representative Fleming for a lot of hard work because he's made this bill better every time they filed it, and I appreciate his work. But I do have those concerns. Thank you very much.
Representative Riley. Was he yes? Excuse me. Representative Sharp.
Yes.
Representative Sheldon.
Yes.
Representative Tate.
I'm a yes, but I'd also like to explain my vote. I'm also appreciative of Representative Fleming and all the work that he's done with this. I know he spent hundreds of hours working on this, so I appreciate that. I, too, appreciate the task force, and I'm going to vote yes to get this out of committee and keep it moving forward. So thank you very much.
Representative Weber.
Yes.
Representative Westrom.
I'd like to explain my vote. I think you've really opened a very delicious can of worms. And I hope I will vote yes for this because I think this is a task force that really deserves to represent all facets of the industry. There's so many of us don't have a background in this, and we need to know from the ground up how it works in different locations and why there's a lag time, why people are waiting. There are a lot of serious issues here, and I thank you for taking this on.
Representative Wilner.
Yes.
Chairwoman Mosier.
Yes, ma'am. Okay. House Bill 777, as amended by the committee sub, passes with favorable expression. Again, thank you so much for all of your work, everyone.
Thank you, members. Committee, and thank you, Madam Chair.
Representative Elliott, would you like to record any votes?
I would, yes, I would. If I have the agenda in front of me, I'll.
I can't hear
I know
you.
I missed House Bill 512. I would record an aye vote. And House Bill 529, I would record an aye vote. Thank you.
Thank you. Okay. Seeing no further business, we are adjourned.